Arrhythmia management is best thought of in terms of what do I need to study? I need to study those things that would be expected of me during my internship. Now that seems straightforward. Now the greatest thing I can do for you is tell you what not to study. Don't study anything complex. You don't say, well, I need to worry about whether it's radio frequency catheter ablation for this particular arrhythmia, or an implantable defibrillator, or some sort of cryotherapy to ablate this arrhythmic tract. The kind of arrhythmia management you need to know is the first hour of management. The kind of arrhythmia management you need to know is, hi, I'm the attending physician. You are the intern in the hospital. Keep my patient alive for the next 2 hours, for the time it takes me to get in from my palatial home in Malibu. Therefore, let's start with this. You have a 47-year-old man who comes to the office seeking advice about diarrhea prophylaxis prior to going on a little vacation to Thailand. He just wants to know about what sort of diarrhea prophylaxis to take. And you notice that he feels okay, it's just that he has a pulse, heart rate. Somebody got me on that one before. Well, pulse is not the same as heart rate. So a heart rate of 47. He's 47, he has a heart rate of 47. Maybe tomorrow, next year, his heart rate will be 48. He has a heart rate of 47. What is the next best step in the management of this patient? EKG or atropine? Or transcutaneous pacing? More history. What kind of history? What kind of more? No, he's not taking any medications. No prior MIs. He's just a guy who wants to go to Thailand as quickly as possible. No symptoms. No shortness of breath. Huh? And then ultimately you say, this is the information you get. You can't go that way on the test, on test day. You know, excuse me, Proctor, come here. Listen, this question, I can't answer it like this. I need some more history on this one. I just won't work under these conditions. I need to know some more about past medical history. No, I've given you everything you're going to get at the moment. So the answer is not atropine and not a pacer, because he has no symptoms. If he had symptoms, if he had hypotension, if he was confused or lightheaded, then you would use atropine. And the first thing to say, are there symptoms? Are there symptoms? And the answer is here, if there was symptoms, then it would be atropine acutely to speed up the heart rate, and then a pacemaker later on. Any kind, atropine and pacer for bradycardia. Any kind of bradycardia that's symptomatic, you use atropine and pacer. Now, if there's no symptoms, the answer EKG was the correct answer. Because if it's sinus bradycardia, first degree AV block, second degree AV block, third degree AV block if it's Mobitz 1 or Mobitz 2. If it's sinus bradycardia at a rate of 47 in an asymptomatic guy, what do you do for a sinus bradycardia at a rate of 47 in an asymptomatic guy? What do you do? Leave him alone. That's right. There's no therapy for that. There's no therapy for that. Normal pulse rate is 60 to 100. But that normal pulse rate of 60 to 100 is just a societal average. Why is 174 a passing grade on step 2? Because that's what we've decided normal is. Above that, you're normal. Below that, you're a part of the damned. Is 173 any different from 174? Is 176 any different from 173? Probably not. Well, you had to draw the cutoff somewhere. And the same as it is with heart rates. Some people are smart and knowledgeable, and they just have less than 174. The same way some people are below 60, and they have no symptoms. That normal heart rate of 60 to 100 is based on thousands of military recruits between the ages of 18 and 24, 2 hours postprandial in the supine position. And if you're thousands of military recruits, 18 to 24, 2 hours after you eat, male, lying flat, that's a normal pulse. But some people are going to be normal and they're just below that. What if his heart rate was 37? What would you do for him then? If his heart rate was 37, what would be the next best step in the management of this patient? If his heart rate was 37. Does he have symptoms? No, he has no symptoms. EKG, that's how come you knew it was sinus at 37. What if it's sinus at 37? What would you do for that? Nothing. But what if the heart rate was 3? A year. What if he's a vampire? What? You know, Buffy the vampire. You know what I mean? He's in Buffy the Vampire Slayer here, and here he is with a heart rate of 3 a year, and he's feeling great, and he's feeling fine, and he's doing merengue, and he's having a good time, and he feels no symptoms. I don't care how low it is. You don't do anything. You don't do anything because he's got no symptoms. And what do you do about first-degree AV block? Nothing. We don't care about first-degree AV block because first-degree AV block doesn't go on to anything. First-degree AV block doesn't become second-degree. First-degree AV block doesn't progress. It's not evil. And the divided line is here. Mobitz 1 is the Wenke Bach. Mobitz 2 is worse. Mobitz 1 is part of the normal aging of the conduction system. Mobitz 2 is associated with ischemia. Mobitz 1 doesn't go on to third-degree AV block. Mobitz 2 does go on to third-degree AV block. Mobitz 1 is not a problem. Mobitz 2 is evil, and it can become worse. So Mobitz 2, even without symptoms, you'd put in a pacer, and the same with third-degree AV block. We don't wait for someone to have their first syncopal episode while they're driving down the opposite lane of traffic from us to have their syncopal episode and pass out at the wheel while they're driving near us. And you put in a pacemaker anyway to prevent the syncope. Mobitz 1 doesn't go anywhere. Mobitz 2 does. And that's how you determine all the bradycardias. Now, you have a 28-year-old female Brazilian medical student who has been preparing for USMLE Step 1. So she's having all of the 4 basic food groups: alcohol, nicotine, caffeine, and chocolate. 4 basic food groups for doctors. And she comes in and she says, I've got palpitations. My heart is fluttering. And she comes to you and says, my heart is fluttering and I have palpitations. And she's got, of course, an EKG, and she has supraventricular tachycardia at a rate of 160. Now, we can go over this management of the SVT and say, give adenosine here and vagal maneuvers here and shock here and beta blockers, calcium blockers, digoxin. And then do AFib and say, we use vagal maneuvers here and beta blockers here and digoxin here, calcium blockers here, shocking here. And then do atrial flutter. We use beta blockers here and digoxin here and shocking here, vagal maneuvers here, and say the whole same thing over and over and over again, like it does in any textbook, like it does in your notes. Or you say, why say the same damn thing 3 times? Put multifocal atrial tachycardia, atrial fibrillation, atrial flutter. All the same. All the same. They're all the same in their management except for one thing. There's only one point of difference between them. There's only one difference in the management between these, which is anticoagulation. Almost, sort of, semi-anticoagulation. New onset, old onset. That's the anticoagulation. New onset, old onset. This arrhythmia is too fast. This arrhythmia is too slow. This arrhythmia is just right. Adenosine. Yeah, that's true. Adenosine is usually reserved for those things that you know that you've just forgotten. So, but I guess. So adenosine is the only point of management that's different between these. If she has palpitations, an SVT, MAT, AFib, A-flutter, multifocal atrial tachycardia at a rate of 160, what's the first thing to do? Don't say an EKG. How do you know there's SVT unless you had an EKG? You had an EKG, and that's how you know it's SVT or AFib or A-flutter. What's first? Step. Next. Cardiovert. Do we shock her? The answer is... Is she unstable? Is she unstable? Well, because that's the point. If she's unstable, in fact, you will shock her. You will shock her if she's unstable. You will shock her if she's unstable. So we better all have the same definition of unstable. Can you imagine this? People come in to the hospital and they have AFib or A-flutter or SVT or multifocal atrial tachycardia. And one of you says, I give her digoxin. The other one says, I give her beta blockers. The other one says, not at all. I'll burn all the hair off her chest and do electrolysis and shock her. Well, we better all have... And you say, well, I'd shock her if she's unstable. Well, what do you mean by unstable? Well, I mean maxed out on her credit cards? I don't know. What do you... We better all have the same definition. What does it mean to be unstable? Hypotension, which is blood pressure. Okay, hypotension on blood pressure. All right, I'm up with that. I'm with that. Sure, I'm with you. Okay, blood pressure, hypotension. I'm with that. Sure. Hypotension. That would mean unstable. Sure. Blood pressure. That's straightforward. That's easy. We can all agree on that, right? We can? Sure. Systolic or diastolic? You say systolic, you say diastolic. Oh, we can all agree on that. Systolic, diastolic, I don't know. What do you mean by unstable? Let's go back to being maxed out on the credit cards. You see. We've got to have the same definition. Now, these things that I'm going to give you for hemodynamic instability are probably the single most important point of data you can get. If a patient is presented to you, and that patient is hemodynamically unstable, that is the most important thing in the question. More important than anything else. More important, is it GI bleeding? Is it cardiogenic shock? Is it sepsis, DKA, burns, bradycardia? Are they unstable? If somebody's in with depression and loneliness, if they're hemodynamically unstable, that's the most important thing. So we better all agree. Because you know how I said chest pain. Forget about everything except positional, pleuritic, or tender. That tells you cardiac, non-cardiac. Chest pain, EKG, ST elevation or not ST elevation. The pivot point, the decision point, is based on stable, unstable. We better have the same definition. So it is low blood pressure, but it means a low systolic. So we can all agree on that. I mean, that's straightforward, right? We can all agree on that. A low systolic blood pressure, sure, that's straightforward. That's easy. We all agree on that. Low systolic blood pressure. How low? 100? 90? 80? 70? How low is low? How low is low? Right? I know. I don't like it when you have to call dropping your pen. I get near her and she dropped it and she goes, oh, I dropped my pen. How low is low? How low is low for you? Less than 60, that's low, I agree. His blood pressure's 70. Yeah, it's all right, it's not under 60. Let him go. It's only 70. So we better agree on a definition. It's a systolic blood pressure less than 90. Systolic blood pressure less than 90. Systolic less than 90. And you say, but I'm 5'0" on a hot day, and I only weigh 94 pounds, and my normal systolic blood pressure is 88. Does that mean I'm going to get shocked? Means yes. Stay away from the emergency room. You're going to get shocked. Systolic less than 90. Welcome to ACLS, Advanced Cardiac Life Support. Welcome to ACLS. Every intern in the country is going to take this. Everybody entering training in the United States has to take it, because I'm not running those codes. Right now at Maimonides in New York, who at Maimonides back at my place is running the codes? It ain't the attendings. It's interns and second-year residents. It's you guys. So that means everybody's going to take it. If not for step 2, you'll take it eventually. Systolic less than 90, shock. What else is hemodynamically unstable? Think. Tachycardia, no. Not going to shock them just because their heart rate is fast. Lower your heart rate. Bang! Oh, it's still fast. Bang! There! Lower your heart rate. Told you, lower your heart rate. Bang! Torture. Now, here's what'll help you. You have to think what shocking feels like. When would you let somebody do this to you? If you're at home tonight, what could you do at home that could simulate the full joys of being cardioverted? What can you do to simulate this at home for yourself? Touch a bare wire? No. Not touching a bare wire. You could be home ironing with your feet in a bathtub. Ironing. And you take the iron and you go. Because that's what it feels like. You put that jelly on the chest in order to increase the conduction of electricity into the heart. In addition, you put that jelly on the chest in order to decrease the burn. Because dry skin burns. So when would you let somebody put a hot iron on you? And you say, never. And you say, not never. You would let somebody do that to you if the alternative was some form of life-threatening, you gonna die thing. Like I got low blood pressure and I'm gonna die. Like I have chest pain, insufficient perfusion of my heart. I better fix it. I don't feel like having a myocardial infarction this evening. Would you like a myocardial infarction this evening? No, how about dinner and a movie? No, myocardial infarction, dinner and a movie. It's so hard to tell. I have such hypoperfusion that I'm having chest pain and I'm going to have a myocardial infarction. What else is like that? Kidney, urine output. Low urine output, shock them. Are you peeing right now? Then shock him. He's not peeing. Shock him. She said, I'm sorry, I'm going to have to shock you. Okay? She said, low urine output. Now, from one point of view, you're right. Low urine output indicates hypoperfusion. Low urine output, insufficient perfusion of the kidneys. I'd like to shock that. That's true from one point of view. The problem is you can't tell now. You're not urinating now, are you? Good, I'm glad you checked. You checked. No, you're not. Therefore, you can't use low urine output because you can't tell now. How would you tell now? Well, it's true. You could intubate the penis. That's true. And put a catheter in there and see if putting a catheter in there, whether or not you had urine output now by putting a catheter in, but it still takes several hours. So you can't use that. It takes several hours. What could you use to tell now is shortness of breath. Shortness of breath. Meaning I can't breathe. Shortness of breath. I can't breathe, and I'm going to have a heart attack because I can't breathe. And the last thing is unconscious, altered mental status, confusion, disoriented, and I'm going to have a stroke. And then somebody always comes up and says, oh, yeah, but I have a question. Yes? People with Alzheimer's disease, they're confused. Do I have to shock them? Shock? No. Hemodynamically related confusion. Hemodynamically related confusion, that's who you shock. If it's insufficient perfusion of the brain and you're going to have a stroke, you got to fix that, and you got to fix it now. So these things are your constant star. What do you see? I see hypotension, shortness of breath, chest pain, confusion. What else is in the case? I don't care. I see shortness of breath, hypotension, chest pain, and confusion. And then you shock. VTAC, AFib, aflutter, SVT, multifocal atrial tachycardia, antiarrhythmia. It's the same thing. How you define it. Well, she's not unstable, she's stable. So what would you do next? Lidocaine is never for atrial arrhythmias. Lidocaine is for ventricular arrhythmias. Lidocaine is for hemodynamically stable VTAC. Lidocaine ventricular. Lidocaine ventricular. Lidocaine ventricular. Lidocaine ventricular. Vagal maneuvers. If someone is rapid and stable, if they're rapid and stable, then it's vagal maneuvers, carotid sinus massage, block down the AV node, Valsalva, now that we finally figured out what it means, block down the AV node, vagal maneuvers. What else do you do to increase vagal tone? Dunk their head in a bucket of ice. That's right. Put their head in a bucket of ice. Yes. What'd you say? Pressure fingers in their eyeballs? Ooh. Huh? Carotid massage, dive. What about rubbing their eyeballs? Carotid eyeball massage? So you're okay? Doc, I have palpitations. Really? No problem. Ah! Well, I guess your mind is off your palpitations, isn't it now? We're not worried about palpitations, isn't it? Like that movie Event Horizon, you know? Where we're going, we won't need eyes to see. Now listen. Vagal maneuvers by pressing on the eyeballs does slow down the heart rate. It does. And the eyeball pressure definitely does decrease the heart rate. Eyeball pressure does two things very successfully. It slows the heart rate and it blinds the patient. Don't do that. As in, Doc, it hurts when I do that. Don't do that. Now, I know some of you are like, but I was told, my teachers, my professors, and people with far more normal nervous systems than you told us that that's what you do. I know. I told you, think of this like group therapy. I know. But eyeball massage causes retinal detachment. And we don't have to. The United States, the American Heart Association, is far more sophisticated and civilized than that. We don't advocate pressing on the eyeballs. Check it in the ACLS book. No, it's far more sophisticated. It's instead of pressing on the eyeballs, you press on the Welcome to America. Circumferential digital rectal examination. Yeah, so change your whole attitude towards cardiac resuscitation. Look at over there, poor Alan over there. He's like, yee, oh, not till after I'm married. Circumferential digital rectal examination, vagal maneuvers, carotid sinus massage. Basically it comes down to carotid sinus massage. You do carotid sinus massage and it doesn't work. What you do next is you would do... Yeah, I'm not making that one up. You got to look it up, the references. Value of circumferential digital rectal exam in management of atrial arrhythmias. Definitely, it's in there. Okay, have you run home and watch the books now, right? If it's SVT, you use adenosine. Hey, I'd expect to stay paying attention after 8 hours, you know what I mean? Adenosine for SVT, and only for SVT do you use adenosine. It's not effective for the others. It's only effective for SVT. Now, if these things don't work, then you have to slow the rate. you slow the rate. You could use digoxin, you could use a beta blocker, you can use a calcium blocker. How will you know which one to use? Because they all have the same indications. They all slow you, but not convert you. They all slow, but not convert you. They all slow the rate, but they don't convert the rhythm. So they all have basically the same effect. They're rate drugs, not rhythm drugs. They're rate, not rhythm. How will you know which one to choose? There'll have to be something in the case that tells you. Now, another way is, some of you are probably saying, well, I'd use DIG, well, I'd use calcium, well, I'd use a beta blocker. And if you're saying that you know, you're basically thinking based on what you saw your attendings use. There's no one as conservative as a medical student or a resident, because you only know what you've seen in your place. Maybe you saw a guy, he said digoxin for everybody. Maybe your guy said, no, calcium blockers, I'd use diltiazem. The answer is they all block down the AV node. It usually goes like this. If you went to medical school in the 70s, you used digoxin, the 80s you used beta blockers, the 90s you used calcium blockers, but it's not really any objective difference. They all slow the rate. They'd have to tell you something. They'd have to tell you something. For instance, what if we said she had a history of asthma? What would that mean? No beta blockers, no beta blockers. So we do this. A, B, C, D. No, well, then we'd use the calcium blocker. They did that. Okay? They'd have to tell you something. It'd have to be telling you something. Now, I recently retook some internal medicine boards, 10-year expiration. And the interesting thing was, rapid AFib that was hemodynamically stable. What's the next best step in therapy? There it is, on cardiology subspecialty boards. Same damn question. I said it can't be. It's too easy. This is straight out of the Step 2 course. And 2 out of 5 cardiology friends I talked to got it wrong, because they answered based on their own little idiosyncrasies. Oh, I've used beta blockers in asthma lots of times, and it's been okay. I haven't seen any bronchospasm. But no, they just wanted you to know, if you have 2 drugs that are okay, don't use the one that has a contraindication. But they're not going to give you questions that say, which of the following is a contraindication to the use of beta blockers? They're not going to do questions like that. It's going to be built into the case. So if they tell you to choose between these 3 things, I guarantee you there's something in the history that's telling you to choose one. Let's give you an example. 72-year-old former president of the United States of America is at a state dinner in Japan, gets up to make an important point, leans forward, and vomits all over the Japanese ambassador. He is found to have rapid atrial fibrillation. He is found to have rapid atrial fibrillation secondary to Graves' disease. And he has rapid atrial fibrillation. He has Graves' disease. His wife has Graves' disease. And who else had Graves' disease? The dog has Graves' disease too. Whew. What is the next best step in management of this patient? What is the most appropriate action at this time? He has rapid AFib, secondary to Graves' disease. What is the most appropriate action at this time? If he's stable, it'll be beta blockers. Because beta blockers will block the effect of the sympathetic outflow from the hyperthyroidism. So therefore, it is the beta blockers. They'll have to tell you something. You know, there's an advantage of taking a board test. I know you don't think there's an advantage of taking a board test, but there is. In life, anything can be anything. But on the boards, they have to tell you something. And if you have 2 answers that look identical, it means they're telling you something in the history that you did not see. And that's how you make a choice. When will you answer Coumadin? When will you answer? When will you answer Coumadin? AFib. Insufficient data, Captain. No. Not enough. Not enough. AFib, not good enough. Not good enough. AFib when? What circumstances? What's going to be in that history that tells you? The what? The size of the atrium. Half credit, half credit. Duration. Ding, 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 ding. That's it. Duration. 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 Chronic AFib. Chronic. Chronic means how long for AFib? For instance, chronic hepatitis B is the presence of surface antigen beyond 6 months. That's for chronic hepatitis B. But how long is chronic for you for AFib? 2 weeks. Not exactly. 2 days. 2 days. For 2 days. Because after you have AFib for greater than 2 days, you become at risk of what? After you've had AFib for greater than 2 days. What happens to you? You become at risk of what? How did I do that? Emboli. You become at risk of emboli after you've had AFib for greater than 2 days. After 2 days, you put them on Coumadin because you become at risk of emboli when you've had it for greater than 2 days. Now you know why I don't say to you, AFib, use digoxin. AFib, use beta blockers. No, AFib, and what's the circumstance? The pivot point of circumstances in arrhythmias is unstable, stable. Unstable, stable. Unstable, rapid, shock. Stable, vagal maneuvers. That doesn't work. Adenosine is only for SVT. After that, you control the rate. Once you control the rate, you use Coumadin to prevent arrhythmia. You have a 57-year-old man. He is at the opera. He gets up in the middle of some Wagner 17-hour-long marathon, Germanic, kill me with opera, gets lightheaded and confused, and is found to have ventricular tachycardia. He has a blood pressure of 128/88. What is the next best step? Management of this patient. What is the most appropriate action at this time? Huh? Constipation. No. Not constipation. Shock or lidocaine? Don't bite your nails. Well, it's from the dim, dark past of 30 minutes ago. Does he have hemodynamic instability? Yes, no. Some of you say yes and some of you say no. That means some of you are right and some of you are wrong. But who is it? Well, the question comes down to, in VTAC, if it is stable, then you will lidocaine, lidocaine, lidocaine. And if it's unstable, then you will shock, shock, shock. So you better be sure, because I'd hate to have poor man's electrolysis and all the hairs burned off of my chest by getting my chest shocked when, you know, we could have given him a little squirt of lidocaine. Yes, but this way he'll never have to go for a waxing again. So the point is, his blood pressure is normal. Is this person stable? No. No, he's lightheaded and confused. He's lightheaded and confused. You shock. He's like this. Hey, oh, hey, oh. Yeah, but your blood pressure is normal, man. You're stable. Hey, ooh, hi, shock. Chest pain, shortness of breath. Hemodynamically related confusion, hypotension. When you see those things, any one of them, you wouldn't say to them, hey, well, you only got chest pain. You're not short of breath. I'll let you just have an MI. Any one of those things. That's the VTAC answer. Let's have another 57-year-old man. Let's have another 57-year-old man again at the opera. 57-year-old man again at the opera. Gets up in the middle of the ring series, falls to the floor, and he's somewhat less than alert. As a matter of fact, he doesn't look so good. And he falls to the floor, and he's not getting up. Hey! What is the next best step in management of this patient? What is the most appropriate action at this time? You can't shock him, you don't know what it is. Yeah, see if he's responsive. Shock. A cattle prod school of medicine. Yeah! Zing! Where'd you go to school? World Wrestling Federation. No, you don't shock him. The guy's on the floor. What do you do next? ABCs. ABCs, ABCs, ABCs. I told you there's no answer that says ABCs. Are you Christine? There's no answer that says ABCs. There's no answer that says ABCs. It's not A, ABCs. B, DEFs. C, GHIs. You have to be very specific. Airway. So you intubate him. Ooh. 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 Hi, welcome in. Wham! Excuse me. Thank you. No. Conscious, unconscious. That is correct. Conscious, unconscious. First thing is to say, Annie, are you okay? Assess to see that he's really unresponsive. Listen, I've seen a lot of seemingly unresponsive people in the opera. I spent 2 years providing the physician coverage for the Metropolitan Opera House in New York, and believe me, 4 out of 5 people were just sleeping, okay? Annie, are you okay? Are you okay? I'm not okay. I'm dead. Before you go head tilting and jaw thrusting and chin lifting, what the hell? All right. I'm sleeping. Assess unresponsiveness. And you find out that he is, in fact, truly unresponsive. As a matter of fact, he is way unresponsive, extremely unresponsive, exquisitely unresponsive. What would you do next in the management of this patient? Intubate. We keep wanting to get to that intubate. Everything. Intubate. No? ECG. You don't have an ECG. Now, this is going to seem stupid to you. I know it's going to seem stupid to you. I know what you're going to want to do. You want to run forward and check a pulse. Look, I want to run forward and check a pulse. We all want to run forward and check a pulse. We all want to run forward and intubate. Believe me. No, we can't. It's not my opinion. This will become clear why. First of all, unless you happen to have an endotracheal tube on you. Oh, yes, I have one right here. Oh, whoa, what? Trachea pull a rabbit out of the hat. No, you gotta go. Yeah, good, you could read. Please cover your left eye and read the lowest line. Thank you very much. You gotta go, help, help, help. He's falling and he can't get up. Help, help. I'm serious, that's it. This is not this Conrad Fisher medical licensure exam. American Heart Association spent 30 years working this out. It'll become clear why. Help, help. All right, you know what? I changed my mind. We're going to do it your way. We're going to go straight to opening his airway. We open his airway. We look, listen, and feel. We do a couple of rescue breaths. And we start those compressions. Check the circulation. He's dead. And he's got no breathing, no respiration. You chart compressions. Now let's do it your way. Ready? So you go straight to opening the airway. And you go and go. You go, come on, kapunka, 3 or 4 or 5. 1 or 2 or 3 or 4 or 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Anything good on TV tonight? No, I don't know. Have I put the Emmy Awards on yet? No, I think they're going to be canceled. What do you think? Yeah. Yeah. Have you seen? Yeah. How long you got that for? How long you going to do that for? Till you get tired. That's it. But you see, what if you don't call for help? The point is this. How long do you have to fix this guy? How long before survival goes from 90% to dead? Like in The Princess Bride, right? He goes, right now he's just mostly dead. He's just mostly dead. How long because now he's all the way dead? How long between mostly dead and all the way dead? And what happened? What can you do for him when he's all the way dead? Go through his pockets looking for loose change. How long do you have? Follow the point. Follow. There's a reason behind this. Because, look, I have no doubt that if I just tell you guys like this, first thing when someone loses consciousness or becomes lightheaded, falls to the floor, is assess their unresponsiveness, call their name, and say, "Are you okay?" This is immediately followed by a call for help, dialing 911. Then you proceed to open the airway by the jaw thrust, the head tilt, and the chin lift. Follow this by checking a pulse, giving some rescue breaths, and performing the rescue breaths at a 5-to-1 ratio with 2 rescuer, or 15-to-2 with 1 rescuer. I have no doubt that if I do that, you'll very dutifully go this, and none of it will stick to you. It won't stick because it's just facts. It's another intellectual enema. Which means you can retain it for a little while, but not permanently. How long? 10 minutes. You have 10 minutes to fix it. You have 10 minutes, like a straighter line. There we go. You have 10 minutes to fix this guy. You know what that means? 10% per minute. Ooh. Oh, now we got a whole new seriousness, don't we? 10% per minute die when they're all the way dead. So you better be sure about the next step. And that means if you go straight to opening his airways and straight to those ABCs, and about 4 or 5 minutes later you go, he's not waking up, we better call for help. After about 4 or 5 minutes, okay, we called for help. Oh, I'm here. Oops, too late. Now do you see why this is here? Because you better start calling for help and get all your toys now, so that you have some chance of fixing this guy. Because if you start to do just chest compressions, and you don't have the endotracheal tube, the EKG, the defibrillator, you're not going to be able to fix him, because chest compressions don't restart the heart. They keep you alive while waiting to get the other equipment, the epinephrine, the atropine, the defibrillator. That will restart the heart. You find that he is pulseless. He is pulseless. What has he got? Kapunk, kapunk, kapunk. What has he got? What causes? What is the differential of death? VFib, pulseless VTAC, which is shocked. VTAC, that's unstable, shocked. And people say, well, pulseless, isn't that very stable? He's dead, that's sort of very stable. Yes, it's sort of very stable or very unstable, depending on how you think of it. So he's dead, yes, but it's unstable, shock. So, VTAC, pulseless VTAC. VFib, pulseless. Asystole, is pulseless. And the artist formerly known as EMD, electrical mechanical dissociation, now known as pulseless electrical activity. Asystole, VFib, VTAC. Oh, well, you better have the equipment, because unless you have the equipment, there's only one way to tell these apart. What's the only way to distinguish these? EKG, because they all look dead to me. So, you assess these unresponsive. Annie, are you okay? I'm not okay, I'm dead. Help! 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 Now you open the airway, start to breathe in, compressions, and you get all the help you can get. Okay? And you find out that he is in ventricular fibrillation. And you find out that he has VFib, and he's got no respirations, no breathing, no air movement, no breathing, no respiration, no air movement, no breathing, no respirations. And what do you do next? If there's no breathing, no air movement, no respirations, and you have VFib, the next best step in management of this patient is... I know, you want to intubate, don't you?
Well, breathing is the first thing.
Breathing is the first thing. I know, you want to intubate. I know you want to intubate. Just say it. Say, I want to intubate. Say it. I want to intubate. I want to intubate. Say it, I want to intubate. I know you want to intubate. I understand. How long does it take you to intubate? How long does it take to intubate? 10 seconds? No, 10 seconds. 10 seconds if you're in the operating room and they're paralyzed with succinylcholine, laid out flat like this with the laryngoscope and the tube like this, and then it's 10 seconds if you don't get it in the esophagus and knock their teeth down their throat. 10 seconds. Yeah, excuse me. Thank you. No, not 10 seconds. It takes some time in the field, positioning them around, suction them out, get the laryngoscope, put that tube in, 10 seconds. Come on. Let's say 3 or 4 minutes. That would be fast. All right, you know what? 3 or 4, 30 seconds, 3 or 4 minutes. All right, we'll intubate. We'll do it your way. We'll intubate. We'll intubate. 3 or 4 minutes, 3 or 4 minutes, 3 or 4 minutes. Yeah, it's all right. Yeah, all right. Yep. 4 minutes. Got it. No problem. Yeah, it's all right. We got the tube in. Okay, what happened? Well, we killed 40% of our patients. Got the point? That's the point? Point is, even if it takes you only 3 minutes to intubate, after you intubate, AFib, what are you going to do next? What are you going to do next after you intubate? Defibrillation or shock? Well, I know it's the same thing, but you said it's different. Shock. Oh. Now do you see why you can't just go with ABCs? Look, if I could let you do that, I would. If I could let you go around and answer every question, ABCs, 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 I'd let you do that. But even if you intubate, you still have to shock later on. This will help you to understand. Shock. Shock, shock. Then you finally get to intubate and epinephrine and shock him again. Oh, it still didn't work? Lidocaine and shock him again. How long do you wait in between each of these shocks? Shock, bang! How long do you wait? Huh? You don't wait. You don't wait. Because if it's you, and I say, listen, every minute, 10% chance of death, you would move very fast. If I told you there's a 10% chance of you being dead every 10 minutes if you didn't get an action done, you would move mighty fast. You'd be like this, bang, 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 shock, done. Shock, shock, shock. How long in between the drug and the shock? No time. Shock. Give him the drug. Shock, 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 shock. Drug, shock, drug, shock, drug, shock. As fast as you can. When are you going to answer intracardiac medications? When are you going to do that? Intracardiac. Take the needle and shoot the drugs, the epinephrine, straight into the heart. When are you going to do that? What? If it's Pulp Fiction and you're John Travolta in Pulp Fiction? On Uma Thurman? Yes, that's right. No, it's John Travolta in Pulp Fiction. Yes, that's about the only time. With the exception, the intracardiac. The answer for intracardiac is never. Never necessary. Never necessary. No greater efficacy, doesn't help, don't answer it. When are you going to answer thoracotomy? Thoracotomy. When are you going to say, oh, arrhythmia management? I gave shock, shock, shock. Squirt in the epinephrine, shock. Gave him the lidocaine, shock. Let's cut open the chest. Zoop. Open the neck, going, When are you going to do that? Thoracotomy and direct massage. When are you going to do that? What? When daddy needs a procedure for the procedure book. That's about it. The answer is that if you've gone and you've done shock, 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 epi shock, lidocaine shock, beryllium shock, and they're still dead, you're out over here. And trying to cut through their chest to go massage the heart won't help. So the answer for thoracotomy is never. When will you answer magnesium? Magnesium is an antiarrhythmic. Magnesium is pretty helpful. Magnesium is a mighty good drug to me. When are you going to answer that? Magnesium is good as an antiarrhythmic. Magnesium goes to the muscles, right? Good for that ventricle. Calms down muscles. Good, right? For arrhythmias. Good for uterine arrhythmias, right? Like in premature labor. Right? As a tocolytic. That's a uterine antiarrhythmic, right? Magnesium. It's only good in one circumstance. I mean, it's good for a couple things, but you'll only answer it in one thing, which is torsade. Torsade de pointe. It's ventricular tachycardia that looks like it's twisting around a point. And it's always sexier to say it in French, I suppose, which is, you could say twist around a point, but it's not as good as saying torsade de pointe. That's the main thing in torsade. That's how fast you go. And no matter how much they say, no breathing, no respiration, no air movement, you are still going to shock them first. You're still going to shock first, no matter how many times they say that the V-fib is not breathing and has no respiration. Because you know what happens if you shock them? They come back to life. And there's nothing like being alive to make you breathe. Right?